There. Another episode of I think I'm gonna call it, what did I say? Mixed medical mentions. Honorable mentions. Today is really just gonna be about CPAP and BiPAP. Um, so I'm just gonna review the protocol. I know I've already done this. This is probably the most relevant and um, thorough, involved, important protocol update in the 2025 protocol guidelines. So let's just read them. And then if there's something to explain or elaborate on, I'll pause and do that. EMT. So I want to be very cautious in mentioning that, maybe not cautious in mentioning, but I think it's worth knowing that just because EMTs can do CPAP does not mean that they must forego or can forego requesting a paramedic. If there's any EMTs watching now, I encourage you to apply CPAP early. You can't use the ventilator, but you can use the device that I'll show you in this YouTube video right here. But there's a lot that coincides with CPAP that's more involved than just the actual positive pressure. So the two things are, well, there's the understanding, the pathophysiology, the why behind CPAP. I think the level of understanding as you increase time and license level and experience with applying CPAP and BiPAP increases. So I think getting somebody on scene who is the highest level with, that has the best understanding of these airway diseases is probably going to benefit the patient more than somebody who has a limited understanding. And then the second thing that I think are all the adjuncts that you add, so they're inline nebulizers, inline duonebs, or albuterol. Um, Adding the end tidal to it, which is very important in determining respiratory rate accurately. I mean, you can sit there and count, but an end tidal does it for you. And then if the breathing's really bad, giving things like steroids if there's an inflammation problem, um, epinephrine if there is refractory wheezing, um, or really bad asthma, and then magnesium, um, and then also anxiolytics. With anxiolytics, you do have to call for them, but it is part of the sort of protocol in administering to patients, and that's not at the paramedic level. So just adding CPAP does not negate a paramedic, in my opinion. Um, that being said, on the other side of things, just because you're an EMT does not mean that you shouldn't apply CPAP. You should be familiar and comfortable with it, and then you should review all the calls in which you did or wanted to or should have applied CPAP. That way you have a better understanding of when to apply it in the future. So I've said this before, I think CPAP and BiPAP are underdone in general, and I think that's why it's been expanded into the EMT scope of practice. Um, if all the paramedics were applying CPAP and BiPAP enough and it wasn't super common or necessary, then we wouldn't be talking about it now, but we are. So, a spontaneously breathing patient, moderate to severe respiratory stress due to CHF, pulmonary edema, asthma, COPD, pneumonia, drowning, or undifferentiated respiratory distress concurrent with the following signs and symptoms: oxygen saturation of less than 94%, retractions or accessory muscle use, and adult respiratory rate greater than 25. I'd say if somebody's respiratory rate is 24 and they still have retractions, accessory muscle use, they look very dyspneic, they look like they're having a tough time breathing, and their saturations meet the parameters, and then you suspect some sort of uh, underlying cause that supports the need for CPAP. So, COPD, asthma, CHF, all that, then you should apply it. Likewise, if somebody's breathing 26 times a minute and they don't have any accessory muscle use, they don't really look, other than the pure number, they don't really look bad. Their sats are 95%. And they're talking full sentences to you without looking like they're much distress, you might not need to apply that CPAP. So these numbers are relative. It's not like, if you see a number that is, they are 94%, but they're significantly working to breathe, then maybe you should consider CPAP. You shouldn't just limit it because there are some left and right limits to this. You just have to validate what that is in your narrative in your treatment section. Um, So absolute indications, if you're not breathing, if you can't pull spontaneous breaths on your own, you can't maintain your own airway, that means that you're so unresponsive that your head is floppy and it requires somebody holding it. That person should be bagged. Vomiting or GI bleed, you don't want somebody to aspirate. Um, Pushing aspirate, geez, I keep yawning, sorry, down into the airway is bad. That will cause pneumonia and alveolar damage and inflammation. Respiratory distress secondary to trauma. You don't want to push air into an already expanding pneumothorax or into the chest cavity when there's a conduit between the pleural space and the lung tissue. That would make the condition worse faster. Suspicion of pneumo, facial trauma, that doesn't, you can't get a mass seal. And I would say, even aside from facial trauma, if you just can't get a mass seal, some patients, I had a patient once that just had no chin, legitimately had no chin. So they were almost not even able to be bagged. And it just happens sometimes. Relative contraindications, unable to follow commands, but maybe they're breathing well enough and you can hold the mask for them and you can kind of coach them through. The alternative is to wait and then the patient goes in unresponsive, agitated or combative. It's probably due to hypoxia. So if you fix the hypoxia, ideally their agitation and combative behavior improve. Likewise, you call the paramedic and then they can administer an anxiolytic if it's necessary and still required. Hypotension with a map, less than 60, systolic blood pressure less than 90. What's worse than hypotension? Hypotension with hypoxia. So certainly if somebody's blood pressure is 60 over 30, that's egregious. I think adding positive pressure, even if you BVM them too intensely, uh, could cause a worse outcome. That being said, some people walk around with blood pressures of 90 over 60 as their baseline. You wouldn't want to forego BiPAPing somebody or CPAPing somebody when they're at their normal parameter. Not everybody meets the black and white textbook. So be cautious with it. Certainly, if it starts to decrease, because maybe you need to back off on the pressure, or maybe the patient is volume depleted and needs a fluid bolus, even if it's just 500 cc's, or maybe they need pressors because they're headed towards cardiogenic shock, but they meet the CHF pulmonary edema guidelines. Because I mean, you can either fix the oxygenation and try to support the blood pressure, or they can have a combination of hypotension and hypoxia. Uh, that's probably going to result in a worse outcome. You have to have appropriate oxygen supply. If you don't, it's going to pull 21. And I will say, and I'm going to get into this later, really the reason for CPAP is not the FiO2. Yes, FiO2 does help if somebody truly needs oxygen molecules, but it's delivering the molecules into the alveoli that's important. And that's what the centimeters of water, the millimeters of mercury of pressure, the 5 to 10, that pushes the oxygen on. You can have a million people waiting to go inside of a concert venue, but until the doors open, they're not going in there. If you apply CPAP and you manually push them through the door, then they go to get then they get to go to the concert. Adjust pressure 5 to 15. Honestly, 15 is kind of high for CPAP. It's not the inspiratory thing that's the problem. It's breathing against 15 centimeters of water that's the issue. That takes a lot of work, and some people don't like it. They'll panic because they'll feel suffocated, and if they're already breathing 40 times a minute, and then you try to have them breathe 40 times a minute against resistance that's too high, that will cause them to not tolerate the mask. And that is different from not tolerating CPAP. That means they're not tolerating the setting that you prescribed. You have to change the setting. Not tolerating CPAP is different. That means it's not your fault. So recheck for mask leaks, adjust the straps. We don't want it so loose that the pressure isn't being delivered appropriately. But then again, you don't want it so tight that they're suffocated and smushing their face down. I mean, the gel ones, it should fit snugly on the face, but you don't have to jam it down. It's gel. It molds to the face. Unless you have those old school yellow ones, those squishy ones. Those do need to be cinched down a little bit tighter. Um, Monitor vitals, check symptoms, pulse oximetry. Please put the patient on end tidal. I mean, legitimately, just do it. Just put the patient on end tidal. Simple. Don't put the inline one. You probably won't get accurate readings, but just, who cares if the little cords on the side of the nose? The benefit of having end tidal, especially with watching the respiratory rate in real time, outweighs the little bit of space that you create by putting the little strings, like the little tubes, um, between the face and, it's not really going to mess the seal up that bad. Recheck your interventions, obviously reassess. It sounds so mundane and so simple, but people don't do it. I don't get it. Just reassess. Is this working? Don't just be like, yep, I put it on, therefore it is working. It has to be working because I put it on. Actually check. Like, I don't want to be dramatic, but like look with your eyeballs and then observe and then say yes or no, this is or isn't working. I don't know. I don't know how else to phrase that, but people don't do it. So if you're sitting there like, oh, of course I'm going to reassess. I see people all the time that don't, and they would never tell me in the morning if I asked them, hey, you're going to apply BiPAP or CPAP to somebody and you're not going to reassess them. They're going to be like, oh, impossible, preposterous. I don't make mistakes. Of course I'm going to reassess, but it happens, which means it can happen to you and it can happen to me. So please reassess the patient. Monitor vital signs, I said that. If the patient's condition improves, maintain the CPAP, especially if there's a risk of, like, if you work to recruit the alveoli and now they're all opened and formerly they were collapsed on each other, and then you suddenly take that away, your patient's going to do very bad and get anxious. If you have pulmonary edema and you push it temporarily out of the alveoli, but then you take the pressure away, it's going to go into the alveoli really quickly, and that is called flash pulmonary edema. Anything that happens abruptly is a lot worse than stuff that happens over time. Patients can have a liter of fluid around their heart in a pericardial effusion, let's say due to cancer. Over months, they can have a liter of fluid from an injury, like a baseball hitting the chest. 30 milliliters could kill them. So if you acutely, and the quicker you insult the body, the faster and the more intense the response is to it, and that could kill somebody. Um, Document it. If the patient deteriorates, discontinue CPAP, and then either BVM them or find out what else is wrong with them that maybe you missed. A DKA patient, I say this all the time, they're breathing 40 times a minute. They might be hypovolemic from fluid deficit, which means that they're, dehydration, which means that their perfusion is not that good. So you might get a low SpO2 sat. What about a DKA patient that has COPD that's satting at 92% at baseline that's just breathing fast? Kablam. Now you have somebody who's breathing fast and they meet the net less than 94%. I'm not saying delay CPAP to check a blood glucose on every single patient, but I'm saying maybe it's not COPD, because if you look at the top, it says spontaneous breathing patient in moderate to severe respiratory stress due to those conditions. So you have to verify that one of these conditions is present. If you just do this, you might inappropriately apply CPAP. Likewise, if you just know that they're asthma or COPD and you didn't assess these other parameters, maybe they didn't need CPAP and you applied an unnecessary, or you went intervention, or you kind of did some overkill. See, look at that. It even says call for a paramedic intercept. If not available, call for AEMT. This is black and white. This does not leave up to interpretation, whatever your political, personal opinion is about paramedics or not. This says call for a paramedic. If not available, call for an AEMT. That means that your license, which is governed by the state, Dr. Wolfson, says to do this. Which, newsflash, you are not an individual practitioner. You work for a physician. His name is Dr. Wolfson, and he's governed by the state EMS office and all the district medical advisors. If your protocol tells you to do something, you literally have to do it. And if you don't do it, you need medical control or some other explanation that validates why you didn't do it. If you are 2 minutes from the hospital, literally 2 minutes, not 20 minutes, and if you're 2 minutes from the hospital, you probably could get there before a paramedic shows up. You can validate that in your documentation. If you're 20 minutes and you think that a paramedic's going to take 15 minutes to get there, that's 5 minutes of paramedic time. That matters. So please follow your protocols. And if you don't follow your protocols, get a physician that supports why you didn't, or write in your narrative why you didn't. If you don't write in your narrative and you don't have med control, and then you didn't follow the protocols, I'm going to ask why. And having this long, drawn out, yeah, but no, but explanation in hindsight, off the record, that doesn't do anything if your if the medical record gets subpoenaed. You have to document why you did or didn't do something, and if you don't do it, there needs to be validity as to why. It needs to be explainable and documented, and or there needs to be a medical direction authorization backing you up. If not, that's a protocol violation. And of course, people make protocol violations, little things, by mistake all the time because nobody's perfect. But if your protocol says to do something, you should do it. And that, I think I've beat that horse to death. Moving on, AEMT, here's a pediatric respiratory rate reference guide. Um, Same indications for the advanced EMT. Um, However, advanced EMTs can do pediatrics. We don't have many masks that fit pediatric patients, maybe the small. Um, Absolute contraindications, impossible face seal. But again, I would say impossible face seal, even if it's not due to trauma. I'd say that's a contraindication. Or the patient's too small. You should bag them using one of the teeny tiny bag valve mask things. Relative contraindications, hypotension. This is a good time to revisit what normal blood pressure is for pediatric patients. MAP less than 60 or less than 90. But then here's the rule: less than 70 plus your age in years times 2. So here's an example: 3-year-old patient, aging years times 2, that's 3 times 2, that's 6. 70 plus 6, the absolute minimum that patient's blood pressure should be is 76. Does that mean that if it's 75, you're doomed? Nope. Does that mean if it's 77, you don't have to worry about it? Nope, because medicine's not black and white. I keep saying this. Okay, apply capnography. That is a standing order for AEMTs. That's a standing order. The protocol has the words, and then the word says apply capnography, and then that means that you should do it. 5 to 15, again, I think 15 is pretty egregious because it's a lot to blow against. Maximum of 5 for pediatrics. Honestly, like 2 or 3 might do it. Document serial pulse oximetry and capnography readings, unless, oh, here's something crazy. You should take more than 1 or 2 vital signs, especially if you're with a patient for longer than 10 minutes. You should take 5 or 10. You should take them every 1 to 2 minutes. They're a very sick individual. That's why they're on CPAP or BiPAP. You should take every 2 to 5 minute vital signs, like minimum. Document serial pulse ox. So, like, if your first blood pressure says 150 over 90, and then you take the blood pressure again, and then it says 90 over 40, do you think that your time taking blood pressures is over? No, it is not. You have 2 extreme blood pressures and you don't know which one is correct. So that means you have to take more, figure out which one's correct. Likewise, if the pulse index or the pleth is bad and your SpO2 says 60, then 94, then 92, then 50, you have to do other things to try to better understand what the patient's status is. Maybe they're too hypotensive or something, and that's a problem. Maybe that patient shouldn't be on CPAP. Maybe they just have fingernail polish. Maybe you need to put an ear clip or a forehead probe or a portable pulse ox if you have one, or use one of the Rappy stickers. Or if you absolutely can't, then document other stuff like mental status, skin condition, and if the patient's not white, then look underneath, look at their nail beds, especially and at the lips, and then the inside of the nose for the nasal mucosa. People document stuff like that, but I've never seen somebody do that. So if your assessment skills are not conducive to doing that level of assessment, maybe you should sharpen them up a little bit or watch some YouTube videos on your own. And then here's the paramedic stuff. This never really this is different. This says specifically POCUS. If somebody tells you that they have interstitial lung disease, or they say they have any sort of consolidation and they can't breathe, and they meet these parameters up here, bing bong, then you should just listen to what they say. Nobody's going to say, I have interstitial lung disease, and then have difficulty breathing in front of you, and then not have it. Like, I don't know who. That's such a weird thing to lie about. So if somebody says that they have one of these conditions, I mean, it does say confirmed on POCUS, but it's reasonable if somebody tells you that to presume that they do. And if they're having difficulty breathing that supports this criteria, then perhaps apply them on the CPAP BiPAP. Anxiolytics, contact medical direction, kablam. Did you know that in the new protocols, there was a whole section designated on what to do if you can't contact medical direction? It is no longer like, huh, I made an attempt. Yeah, I like picked up the phone and then I just saw that there was no service. You have to write a whole incident report about all the things you did and didn't do and why you couldn't contact medical control. And then you have to submit it to the state. Oh, yeah. That means that if you can't reach a physician somehow, landline, multiple cell phones, radio, or multiple radios, or contacting somebody by radio who can relay or something like that, it's kind of a big deal now. I mean, you have to document in writing why you weren't able to contact medical control. So if you actually are able to contact medical control, the easiest thing is to just do that. And then there's the doses. It's pretty much half. IV, intranasal, midazolam. That's probably what I would do. Can repeat once. Yeah, so you probably shouldn't give 3 doses. Okay. So administer benzodiazepines in patients with caution in patients with hypercarbia. When you breathe poorly and you have COPD or any sort of like restrictive thing that causes retention of air, if you need more time to breathe out, but you can't because you're breathing too fast, you're going to retain CO2. That's why smokers and COPDers and patients with emphysema especially have chronically elevated levels of CO2 because they retain. So you do a blood gas on them and their CO2 at baseline is like 55 or 60, but their acid base, their pH is normal. That's because it's compensated for. Uh, if you have somebody who's breathing bad and their PaCO2 is 80, and then let's just say their end tidal happens to be exactly 80 as well, and then you slow down the respiratory rate, just like in somebody who overdoses, that's going to make them breathe slower, which means they're not going to breathe off as much CO2, which means that they're going to retain it. And now their CO2 went from 80 to 110. Patients with CO2 for a prolonged period at like 90 to 110, they require intubation or they die a lot of the times. So if you induce bradypnea and the patient's already hypercapnic, that is a problem. Okay, so there's that. Next, here is the device. I'm going to post this video separate, so if you want to just watch the video, that's fine. But, I encourage you listening to everything I have to say. Here we go. Okay, did you guys hear that? These masks are gel. They do not need to be smushed onto the patient's face. This is too loose. this would have to be tightened. I'm sure he's gonna tighten it. But mashing it down, the gel ones, this fits to the face. It's gel. It contours to the face. Um, if it's too loose, you're gonna get too much of an air leak. That's gonna limit the amount of pressure going in. If it's too tight, it's gonna smother the patient. They may not be able to exhale all of that air out on their own, and then they might panic and rip the mask off. And then you're gonna be like, well, they couldn't tolerate it. Nope, that was your fault. You did that. Please don't. Oh, by the way, for the Zoll vents, Z vents, the exact same stuff. So you could swap it. But I mean, if it's working, you might really not need to. But BiPAP is obviously nicer on the patient. It's easier to tolerate. It's more comfortable. So if you have the ability to switch from CPAP to BiPAP, then you should probably do that if you're a paramedic. Likewise, if you push this, like if any of this plastic is touching the patient's skin, it's going to pinch. If this here is off to the side, it's going to smush the nose or, and like that's uncomfortable. And now your patient's in pain. And then you're like, yeah, patient won't tolerate it. You hurt your patient. And then, so that's not tolerating it. That's just being reasonable and not liking the painful stimulus that you applied to the patient, which any normal person would not like that. So I think people oops, come on, let's go back a little bit. I think people underdo this. People have different shaped foreheads. If the forehead and the nose are small and this is a very flat area, you have to push this in. If the nose is big or the forehead comes out, I mean, you have to adjust this. There's like four, I think, click settings here that you can put it on. You can also move it up and down, change this up and down as well. Just take the time initially to apply a good mask seal. Just take the time. I don't know what else to say. Hold the mask to the patient's face in the exact way you want it, and then tighten these straps so that the mask stays how you're holding it, is if the patient's able to tolerate it. Have your partner help you. Like CPAP, if you've made the decision to CPAP somebody, it's probably the most important thing you can do for them. So all your attention should be focused on doing that intervention, completing the intervention, assessing that it's working, verify that it's improving the patient's overall condition, and then move on. If you have the resources to do this plus other stuff, then of course do the other stuff, right? Probably don't take a 12 lead before getting an IV. I don't know. Do it however you want, but this is a very important priority. And if you don't do this and you do other stuff like a 12 lead and two IVs and a blood glucose and put the patient on end tidal, you're kind of dropping the ball a little bit. Takes time to build up recruitment. You never know how long it's going to take for somebody to crump. And so whenever you can interject this break in the chain of respiratory doom, whenever you can be like, it's minute 10, and then you put the CPAP on, you don't know if they would have crumped at 2 days or minute 11. You don't know. So you have to apply it as early as you can. And then the hope is that you make the patient's condition improved. So at least you know that you're on the right pathway that benefits them at the hospital because they're like, yes, respiratory therapy. We need them to come down. They're busy. And there's like maybe three or four of them in the entire hospital someday. Do you think there's just three of them sitting in the ED waiting for random patients? No, they're probably up in the ICU or on med surge doing stuff. So it behooves you to apply this, verify that it's working and it's the correct intervention, and then call a hospital. Like, hey, just so you know, I'm putting a patient on CPAP or BiPAP. Respiratory therapy is going to need to be there. We're still on scene. We'll probably see you in 20 to 30 minutes. That's a very nice thing to do for hospital planning purposes, if you can. Probably don't call them before you put the CPAP on and be like, hey, by the way, we're putting CPAP on somebody, because now you're withholding an intervention to make a phone call that you don't need to make before doing the intervention. So, anyways, um, this is important. Do this. Do this on your patients who have like constrictive lung diseases. If they have wheezing or they have very diminished breath sounds in the bases, please put albuterol or Adunab into this. You just open up a mask or a pipe, and then you take the normal canister and then you fill it with albuterol or a duoneb. Then you attach it here. This is a 22 and this is a 15 millimeter adapter size. And then you put your canister there, you attach your oxygen hose to another oxygen source, 6 to 10 liters. I usually do 8. And then you run it in conjunction with this. There it goes. If somebody's laying flat or too far tilted, the medicine is going to leak up here and spill. So they have to be pretty straight when you do it. So patient positioning, there's a whole new protocol about patient positioning. Pay attention to it. Just pay attention to it. Put the patient in an ideal position and prop them if they need to be propped. And don't just half butt it, right? Like do it deliberately and correct the first time so you don't have to come back to it. And you're just wasting time. Just do the deliberate action to place the patient in a position of comfort that's conducive to the procedures that you're doing. Just make it an effort and a point to do it. It's in the protocols now, which means that people aren't doing it enough, because if they were, they probably wouldn't have taken all the time to make a whole protocol about it. So that's it. Okay. The last thing I want to talk about is the actual science a little bit. I hope this works. I have a mouse. It's not going to be great. Okay. So, I wish I had a stylet, but I don't. So you have a patient's mouth and then their airway and then lungs. Okie dokie. When you breathe in air and it goes into the lungs and then into the alveoli, and then at this alveolar capillary membrane, the air, the FiO2, the actual oxygen, right? The pressure of oxygen, which at this junction is like 7 to 12 centimeters of water. Whoa, that's crazy. That's why probably CPAP's 5 to 15. Who would have thought? The air moves from a place of high concentration to a place of low concentration. CO2 moves from a place of high concentration to a place of low CO2 concentration, and that means that gas exchange occurs. And then ventilation moves that gas that was exchanged in and out so that you have what's called cellular respiration, and the cells then get oxygen and release waste products, and then you have what's called metabolism. These are cells or alveoli, whatever you want to call them. And then metabolism makes ATP, and ATP keeps your body from dying of death. So that's the generic physiology, the anatomy and physiology of why you breathe like that, or what all this is about. So now let's say, I'm gonna draw this a little bit bigger. This is a lung. Of course, this is exactly what a lung looks like. And then now let's draw it even bigger. You have an alveoli and a bunch of oxygen that needs to go into this capillary. That then needs to go into a, arteriole. I guess in this case it'd be a venule, and then into a vein, and then into the vena cava. Well, actually, I guess in this part it would be going into the pulmonary vein, and then into the left ventricle, and then out into the body. Kablam, out the aorta. Now oxygenated blood is going into the body. So can you imagine there's really 3 ways why oxygen won't get from here across this membrane. All right, what are they? Diseased alveoli. Not working. Diseased alveoli. Who has diseased alveoli? COPD and emphysema patients, and then patients with genetic disorders, or patients that inhaled like smoke or something hot. They have bad alveoli. That impairs gas exchange. What else? Patients that have a patients that have a process that's not getting air into the alveoli, like restriction from asthma, inflammation, airway obstruction from mucus. How about just a slow breathing rate because they've overdosed? Those patients have like a central brain problem, and now air is not moving into the alveoli. So you fix that underlying cause, whatever it may be. But now let's keep going. So I got a little sidetracked there. To summarize, you either have a problem pushing the air in through this restriction, and if there's restriction, you give stuff to relieve the restriction. If it's really bad, you give epinephrine. If it's okay, but they still need medicine for it, you give them albuterol or Odunab or magnesium. You know, if you're a paramedic and you've already tried this stuff and it doesn't work. And then you place the patient in an optimal position to facilitate good, you don't want their diaphragm and their big obese belly pressing against their lungs. That'll be bad. So pick them up or sit them up. And then, so what's the other thing? So pretty much one way is oxygen's not correctly getting to the alveoli. Fix that problem. The alveoli has an issue from COPD, emphysema, a disease, or an acute process that actually damages the alveoli. Fix that problem or provide supportive care if you can't fix it. What else? Patients that have pneumonia and atelectasis where these alveoli flatten and don't stay open, those patients need PEEP to pop these open. Add PEEP, pop them open. Okay? This is called lung recruitment. When an alveoli goes from this to this right here, that is lung recruitment. That takes time to develop. And when you pull positive pressure away from somebody after applying it for however many minutes or hours, you then degrade the amount of recruitment that you just worked for. So don't do that. Unless the patient truly isn't in respiratory failure anymore and their blood gases are perfect, which you can't test pre-hospitally, right? And they've been evaluated by a physician, you probably shouldn't take the stuff away. Or don't just apply it for 2 minutes. Take it away unless it's the patient's condition's getting worse. Okay, so summarizing again, central problem where the brain is not, something's causing the body to breathe shallow or not enough times, like pain or trauma to the chest, or a drug overdose for central apnea, or a tumor or seizures, anything like that. There's restriction on the way in, so give them something to dilate that restriction. There is an alveolar problem like COPD, emphysema. There is atelectasis or lung recruitment problem for which you add PEEP. And then here's the last part of it. There is a low, just like you have low air coming in if you're breathing slow, you can also have low blood going to the capillaries. What causes low blood? Jeepers, it's hypotension. What can we do about hypotension? It's almost as if we have vasopressors and IV fluids. That's a crazy concept. So, any low perfusion shock state, right? Some patients with horrible acidosis, maybe, or some sort of like poisoning. And then lastly, the patient is so sick with a respiratory problem that they have this alveoli, they've got a normal capillary, but due to cell permeability and then the organ dysfunction, right, the systemic inflammatory response and then the organ dysfunction, they get all this crap developing in here, which appears on a chest x-ray as, well, here's a term that people have heard before, ground glass opacities. That just means that schmuck is in between here. Well, guess what? That means that it's harder for these dots of oxygen to cross this membrane. Instead of going across the paved bridge, they're now walking backwards through the mud. That means that not as many dots are going to go over here, which means less gas exchange, which means, do you know what you have to do? You have to push them in using pressure. Guess what adds pressure? CPAP and BiPAP. Whoa, that's crazy. So if the patient didn't need help getting the air across with pressure, they wouldn't have called 911. But guess what? They did because you're there. You should probably do that for them. They don't know how to ask for this because chances are they're not a doctor. So you have to assume that that's what they want because they called you for a breathing problem. They're hypoxic, they're tachypnic, they have COPD, emphysema, asthma, pneumonia, reactive airway disease, bronchiolitis if they're a kid, although if you're an EMT, we're not doing it for kids. Um, and then we're limited by the mask sizes that we have in stock, right? So like you have a story, it paints a picture towards needing this. They meet the parameters, plus or minus a little bit, 95%, still not a lot of extremis. I'd consider applying CPAP, 93%, but totally fine. Maybe just apply some oxygen. Anywho, so to recap here, the problem is you can't get oxygen molecules from one side of the membrane in the alveoli to the blood, and that is either due to not getting the air to the alveoli, and that's because the patient's respiratory rate is slow, or it's very fast but shallow, or they have restriction. So if it's really fast, shallow, or slow, you bag them. If there's restriction, you give them epinephrine, albuterol, magnesium, whatever they need. But start if they're about to die, give them epi. But if they're not about to die, then start at the normal albuterol. Duodeb. Um. So that's yep. And then if they have a COPD problem with diseased alveoli or emphysema, then you add PEEP and you give things like steroids, but the PEEP is added through BiPAP. How can you add PEEP not through BiPAP? You can't. Well, positive pressure ventilation, that's the only way, baby. So you can't just applying somebody on oxygen does not add PEEP. These patients need PEEP. The easiest way to do it is to add BiPAP because it's the nicest. Then it's CPAP. Then it's bagging. Then it's intubation. That's the sequence. If you don't fix the positive pressure issue, that's what happens. Your patients die of death. And then lastly, there's a low perfusion state or a shock state. So you increase the blood pressure using fluids, vasopressors. If their blood pressure is bad because they're dehydrated, you give them IV fluids. If their blood pressure is bad because they have a ton of narcotics or heroin or something on board and they're totally vasodilated, you give them Narcan. You do whatever the underlying cause, whatever's going to treat that and make these symptoms better, do that. Because then you don't have to provide supportive care to the symptom. You can get rid of the symptom by addressing the underlying cause. If the patient has a leaky gas tank, I guess you could keep filling the gas tank, but that's a lot of resources and it's only temporary. You fix the hole in the gas tank and then you prevent the gas from leaking. That's what we're talking about here. Um, and then lastly, there is some, you know, matrix or substance or sloughing of endothelial cells or mucus or infection or goop or whatever you want to call it, right? That talk is beyond the scope of what I'm doing. In between the alveoli and the blood, and then you know what fixes that? Still positive pressure, high FiO2, because the higher the better in some of these very, very sick patients. Um, if the patient has a hard time getting the air out, you increase the expiratory time. If they have a hard time getting the air in, you give them something that relieves the restriction, like albuterol. And then if your patient's blood pressure is low, you increase their blood pressure. Mm-hmm. And then when they get to the hospital, this patient is going to get antibiotics. That's crazy because that's the underlying fix. And then, of course, they'll get like, a bunch of other adjuncts that we don't have in EMS. So to summarize, let me go to a new one. Don't save. Okay, problem. Patient can't get air into lungs. Why not? Not enough pressure delivering it to the lower airways. Add pressure. Do that using BiPAP. So when you put, let's say you put somebody on 5 centimeters of PEEP and it doesn't quite get enough air to go in, you increase it to 10. Cool, 10. But on CPAP, that means they also have to breathe out against 10. And that might be hard for them to do if they're weak, fatigued, or anxious, or hypoxic, or they just don't have strong muscles anymore because they've been using their secondary muscles to breathe this entire time. Those patients probably don't have the muscular capacity or energy anymore to push air against resistance. Okay? That's like saying you're on mile 23 of your marathon, and then somebody's like, hey, I know what I'm going to do for the last 100 feet. you're gonna like push a small car across the finish line, or you're gonna carry somebody on your back. Patients sometimes can't do that. So if they're having problems breathing against that, then you need to lower the overall pressure. But what if the overall pressure of 10, let's say you lower it to 6, because that's what they can tolerate exhaling, but let's say that 6 is not good enough inhaling. Jeepers, what does this patient need? They need something that, I don't know, starts with this and that ends with this. That's called BiPAP. So you should put the patient on BiPAP and do some sort of like, 10/5, 12/6, anything like that is within the reason of like, if you do that, you're going to know it's either not working, then you add to it, or it's a little too much and you take away. Titrating, once you've established an improvement in the patient, you're like, okay, but now I can make it a little bit better. Go from 12 to 10, go from 6 to 4, go from 5 to 7. I don't know. You play with it a little bit, and then you can do this crazy thing that's called ask your patient if they think that it's working and if it sucks for them. If it sucks for them, change it. If it's working, then just leave it. So, okay, to summarize what we've talked about here, there's a very important reason for CPAP. It's underdone pre-hospitally by all providers, which means you should be comfortable in doing it to more patients. That being said, I really don't want to swing the pendulum this way. Here's the pendulum. This right here is not enough CPAP. We want more CPAP, but we don't want to start CPAPing trauma and DKA patients and doing it inappropriately. So we need to find a happy medium. That happy medium comes from being familiar with CPAP, being familiar with the pathophysiology, knowing all the adjuncts like epinephrine, albuterol, inline nabs, duo nabs, improving the blood pressure if their blood pressure is bad, if the patient's hypothermic, making them warm, like literally whatever the underlying cause is, and you can fix it, fix it. If there's an underlying cause that you can't fix, take them to the place that can fix it. That's called a hospital. And then if there's something you can do to support the symptoms, but you can't do the fix, then you support the symptoms. We can't fix pneumonia, but we can add positive pressure and make the breathing better. Because what's worse than pneumonia? Pneumonia and hypoxia. But you could do something for the hypoxia. So why wouldn't you do it? That's the theme here. That's what we're going for. So I don't want to swing the pendulum too far this way and start CPAPing DKA patients. I don't want to leave the pendulum over here because I don't think we're CPAPing enough. So just keep this idea in mind and CPAP more patients, but don't CPAP too many. Easier said than done, right? And then understand the pathophysiology behind CPAP. We're trying to add pressure. This is called the driving pressure, by the way. If the patient could do this driving pressure force on their own using their own intrinsic PEEP, they probably wouldn't have called 911. They called you because they can't. So that means you have to externally do it. There are no interventions on the ambulance, 0, not 1, 0, that can add positive pressure for you. That means for the patient. That means you have like dexamethasone does not add positive pressure. Albuterol does not add positive pressure. None of it adds positive pressure. BVMs, PEEP when the patient is intubated, CPAP and BiPAP, and to a lesser extent, high flow nasal cannula, those add pressure. If you think that a patient that requires pressure is going to get better from oxygen, albuterol, and solumedrol, you are not correct. You're just simply wrong. So if you're giving your adjuncts and it's not fixing the patient and they're still tachypnic, it's probably because this is what's probably happening. Here's their head. Here's their lungs. They're breathing 40 times a minute and the air is ending here in the upper, mid upper airway structures. And then they can't talk to you because they're breathing so fast and it's not making it down here, which means this patient is retaining CO2. They're getting cellularly hypoxic. They are switching to anaerobic metabolism. They are going to get tired and they are going to pass out and maybe even die of death. So you're like, okay, maybe it's restriction. Maybe it's from wheezing, from airway asthma. Okay, that's fair. You give them albuterol. It dilates stuff. Now maybe the air only gets to here. So you look at your patient, maybe they're satting at 92%, 94%, 95% because you gave them a ton of external oxygen. You increase their FiO2 from 21%, which is room air, to like 50% or something, just random. I'm just making an example up. But the air is still here. You're like, holy crap, air not go from step A to step B. How do I make air go from step A to step B? I push it. How do I push it? With BiPAP first, then CPAP, then a BVM, and then if the patient's unresponsive, no gag reflex, an endotracheal tube. Yep. So, and if you add too much pressure, you might accidentally push some air into the stomach, which might increase the chance of vomiting or nausea. Likewise, if you put a bunch of pressure and you hyperinflate the lungs, all that pressure is going to push against the inferior and superior vena cava, which means it's going to limit the cardiac output. Sorry, the blood going back to the heart, which means blood in the heart is going to go down. And if blood going to the heart goes down, then blood going out of the heart also goes down. And what does that mean? That means low blood pressure. That means reduced cardiac output. That means shock. Shock is not good. We learned that in EMT school once. So if you can't make the air go from A to B with all of your adjuncts, then it's time to push it there with the right amount of pressure. Start at 5. If you're a ped, start at maybe like 2 to 3, go to 10 if it's not enough. If you're like, good golly, Miss Molly, oh my goodness, what the hell? 10 is too hard for them to breathe against. Good thing there's something for that. It's called BiPAP, standing orders for paramedics. Put them on BiPAP, make it easier for them to breathe that air out, not against as much pressure, and you're still providing inspiratory support, which CPAP does as well. There you have it. Ooh, I wanted that to be 30 minutes. I have a feeling it was probably close to an hour, if not more. So very thankful if anybody stuck it out and watched this whole thing with me. I really, really hope that we can do more CPAP, BiPAP with comfortability and then review the cases together, or at least with your partner or the crews that you're working with. Follow up on the patient at the hospital. And then if there's something that you need help with, whether it's patient positioning, mask adjustment, the anatomy and physiology or pathophysiology of lung diseases or air going in and out, or you want to become a nerd with it and you really want to get better with the Z-vent, or any sort of invasive or non-invasive airway stuff, then please reach out. And then be mindful of your indications or contraindications. And of course, if you don't do something that you should, call med controller, document why. If you go a little bit to the left or a little bit to the right, that's okay. Just document why. Respiratory rate greater than 25, and you're telling me you're not going to do it because it's 24? Nope. It's not black and white. Medicine's not black and white. How about a toddler, 1 to 4, breathing forward? But what if they're 5? But what if they're a little smaller than preschool? You know what I mean? Like there's it. If somebody's egregiously outside of the parameter, then you got to kind of reconsider, right? But if they're like plus or minus 5% and it's within wiggle room of this rough, because nobody's black and white in medicine, right? We don't do case reviews on black and white stuff. That's boring. Then but just document it. Say, although say the patient was breathing at 22 to 24 times a minute, but displayed a high degree of respiratory distress that was refractory to supplemental oxygen. CPAP was trialed, and the patient had an improved outcome, so therefore it was left. That's all you have to do. Okay, great. Thank you very much. If you stuck it out with me, if you want credits for this, just send me an email and say that you watched it and you listened to me ramble for, I don't know, an hour. Well, 54 minutes, not bad, but that's one subject. And I'll give you some credits for it. If you're part of Berrytown, I'll write you something on Vector, or I'll add it to Vector. And if you're not part of Berrytown, then I'll send you a certificate in a PDF like I normally do. Okay, thanks. I hope everybody has a good night.